Hi. Welcome to the Jewish Orthodox Women Medical Association podcast. I'm really excited to be here today with Dr. Sara Crystal. My name is Elisa Minkin, and I am your host and a proud JOMA member. And so welcome, Dr. Crystal. Thank you so much for joining me.
Thank you for having me.
Absolutely. Dr. Crystal is a board certified neurologist and UCNS certified. What is that?
It's the United Council of Neurologic Subspecialties.
Wow, certified headache specialist. She completed her neurology residency at NYU, where she served as a chief resident, followed by a fellowship in headache and facial pain at the Montefiore Headache Center of Albert Einstein. She is a neurologist at the New York Headache Center and a member of the American Headache Society and International Headache Society. That is a lot of headache societies. I'm really impressed, and I think it shows how important and how common these problems are. I myself get migraines, so I'm interested in learning more. So let's just start with, I'm calling this more than just a headache because a lot of people are confused. They either think every headache is a migraine or they don't understand that they're having migraines. So what is a migraine and what makes it different from other headaches?
So migraine, first of all, I want to just emphasize migraine is extremely common. So overall, about 18% of women in this country have migraine. And when you look at the prevalence specifically in women in their 30s, it's more like closer to 30%, who have experienced a migraine at some point in their lives. So we diagnose migraine when someone's headaches have the following features. At least 2 out of 4 of the following: that they're one-sided in location. In children, they're more commonly bilateral, moderate to severe in intensity, throbbing or pulsatile, and worsening with activity like running, going up and down stairs worsens the pain, and at least one of lighter sound sensitivity or nausea, vomiting. So if you have those features, then you have migraine. A simpler way to diagnose it, there's a tool called the ID migraine tool, which is good for patients. It's good for non-headache specialists as well. It's limited your activities in the last 3 months. For at least a day in the last 3 months. Do you have?
We lost a second of yours.
Oh, okay. Yeah, sorry. Has a headache limited your activity in the last 3 months? Do you have nausea with your headaches? And are you sensitive to light during headaches? So if someone responds yes to 2 out of 3 of those, then it's highly sensitive for a migraine diagnosis. So different than your typical, I got dehydrated and, my head hurt a little bit, then I drank or took Tylenol and it went away. That is, much more, usually more severe, more disabling, and can also be accompanied by neurologic symptoms, right? So about 20-25% of people with migraine experience aura at some point. So aura is defined as reversible neurologic symptoms. So the most typical type of aura is a visual aura. So people describe sparkling light, sometimes lightning shapes, or sometimes blurring of vision. Usually it starts in the periphery and it can move across the visual field. These aura generally precedes a headache. It can last up to an hour, but usually lasts around 5 minutes on average and is often followed by pain. Other less common types of aura are sensory aura. So people might feel a tingling or numbness on one side of the body. And even less common is a speech disturbance. So people can't get the words out during that type of aura.
Who gets migraines?
So women primarily. So and mostly in their productive years.
From puberty.
So say again.
So from puberty on?
From puberty on in women. In boys, actually, the average onset is younger. It is before puberty, but overall, migraine is 3 times more common in women than men. And like I said, overall, 18% of women in this country, 6% of men. About overall 10 to 11% of teenagers in the U.S. have migraine. So quite common.
What are some of the different triggers of migraines?
So the cause of migraine is genetic. So if you have it, I'm sure you can find someone to blame. In my case, it's my grandmother. Um, but um, but
Hold on.
that's that's the
Common
cause.
though. Yeah.
Yeah. Yeah. But in terms of, so basically what that means is people, we have a genetic tendency to have this lower threshold that when we're exposed to certain triggers,
Mhm.
are this whole cascade of migraine, this whole migraine party starts in our brain. Whereas in other people without this tendency, nothing happens. So the triggers can be, vary so much from person to person. Some of the common ones are hormonal changes. So, around, people around their periods will get migraines, certain foods containing MSG, nitrates like deli meats, foods overall high in tyramine, that like aged foods, pickle foods, those tend to be migraine triggers.
Does that
Artificial
include
sweetener.
chocolate? I'm sorry. Does that include chocolate?
So right,
I
so
heard that
chocolate,
it's in
yeah,
your list.
I
Please say
know,
no.
because you know what? Chocolate, probably not. Even though
Oh,
yes, I know, it's long been blamed, but
yes.
a lot of these triggers, what we think is actually a trigger is actually a craving that's a premonitory symptom to the migraine, right? So you don't realize it, but the migraine's already in progress.
Mhm.
You just don't have the pain yet, but migraine as a whole, has different phases, and there's a
Yeah.
prodromal phase where before you even feel the pain, which may or may not include aura, but as part of the prodrome, people have appetite changes, cravings, and they might reach for chocolate, and then a couple hours later develop they get into, and then they blame chocolate. So that's probably why chocolate got a bad rap, but it doesn't actually seem to trigger migraine.
It won't make it go away, unfortunately, either, though.
Yeah,
Maybe
yeah,
some
no,
B vitamins in the chocolate or something.
yeah,
No.
be a good product, a migraine chocolate. That would be a good treatment
Right,
actually.
right. To think about. Okay.
And of course, alcohol. Red
Mhm.
wine,
Right.
particularly. So in terms of alcohol, the darker the drink, the more likely it is. The higher in tannins, the more likely it is to
Mhm,
trigger
mhm,
migraine.
mhm. So, how would you determine whether you needed to get help? Since migraines are very, very common, not everybody who has a migraine needs to see a doctor about them.
Yeah. So if they're infrequent, and you respond to over-the-counter medications, then that's fine. I mean, most people with migraine are not, at least, definitely the people I see are the ones that over-the-counter medications don't work for. You have to be careful though, if you're taking something frequently, particularly Excedrin, because of the caffeine in it, it can cause rebound or medication overuse headache. So if you find that you're taking acute medications for sure 4 or more days per month, and it's probably time to talk to a doctor about your headaches.
What is
It
this
may
medication overuse? Because I actually read somewhere that that may not be a thing, just like chocolate. So,
Right. So that concept has definitely been rethought in the last few years. It used to be thought that using pretty much any acute medication more than 2 days a week on a regular basis, like over a 3-month period, can contribute to rebound or more frequent headaches. Um, but it's a little bit controversial. So what I'll say is that the medications that we know that contribute to this are barbiturates. So there's a commonly prescribed medication called Fioricet that has barbiturate in it, and as well as caffeine, and that seems to definitely cause rebound headache. Opiate-containing medications, um, and then even over-the-counter medications like Excedrin. So because of the caffeine,
mhm, but
caffeine
not
is one of those things.
non-steroidals, like, or Tylenol.
Probably not.
You could
Probably
take
not.
them.
In fact,
Mm.
yeah, moderate NSAID use is probably somewhat protective against rebound headache. Um, so caffeine is interesting because it's one of those, it's kind of a double-edged sword, right? So
Mhm,
acutely, it helps during a migraine attack because it constricts the blood vessels in the brain temporarily, in the head temporarily. So but long-term overuse of caffeine. So um, basically the cutoff that we tell people is more than 200 milligrams of coffee a day, which is about 2 cups of coffee, of brewed coffee a day, may lead to more frequent headaches.
Mhm, mhm, mhm. Are there tests that should be done for someone with migraines, like, evaluation?
So in general, as long as someone has a normal exam and no red flags, which they fit a migraine diagnosis, and there's nothing concerning about their stories, such as um, thunderclap headaches, like headaches that come on in seconds, or headaches that consistently awaken someone at night, or unusual neurologic symptoms with headaches. So in the absence of red flags and with a normal exam, most people don't need, imaging or other
Right. The,
tests.
the reason I mention this is because as a pediatrician, that's what parents want. They come in, my child has headaches. They're worried it could be, God forbid, a tumor. I had a patient just the other day who went to the neurologist with, what sounded like migraines and never went back because the scan was normal.
Right. Right.
He
Right.
said,
They feel,
okay,
yeah, for some people, that's all they're looking for is reassurance. But,
right.
if you want, I explain it that an MRI there's no test to diagnose migraine. It's a clinical diagnosis based on those criteria that we discussed earlier. We do imaging when we're worried about something else going on.
Mhm. Or we don't want to miss something.
Right.
Or just the kind of medicine we practice.
Yes. Yes. The pressures external pressures.
Right. So what are the different treatments and how effective are they?
So, in terms of acute treatments
Mm.
for migraine, the sort of the gold standard is a triptan. So there are 7 different triptans. Some familiar names are Imitrex, Maxalt, or the generic name sumatriptan, rizatriptan. There are different forms of triptans. There are injectable triptans. There's nasal sprays. Those tend to work more quickly than pills. There are newer medications, really just in the last year, a class of medications called GPANTs, which work by blocking a protein called CGRP, which everybody has. It's widely distributed, but is elevated during a migraine attack. So those are some of the acute treatments. And then in addition, we also give anti-nausea treatments as needed, and sometimes non-steroidal anti-inflammatories. And then there are the preventive treatments. So we generally consider a preventive treatment when someone has, more than 4 or more days of headache per month. But it might vary depending. Someone might have only 1 or 2, but they're very disabling or long lasting. Or someone might have 6, days of headache a month, but not necessarily need a preventive. Maybe they just never tried an effective acute treatment. So, but we generally use that cutoff. When it comes to preventive treatments, there are sort of non-specific treatments. These are the treatments we've been using for a long time for migraine prevention, unlike triptans, which have been around now for 30 years almost, which were developed specifically for migraine. Most of the preventives we use for migraine were developed for other medical conditions, but found to be helpful for migraine. So the 3 major classes are the blood pressure medications like beta blockers, calcium channel blockers. So things like propranolol, verapamil, the antidepressants, specifically the tricyclic antidepressants like nortriptyline and amitriptyline, and then the anti-seizure medications like topiramate, Depakote, and gabapentin. Now with these medications, you probably, realize you're going to be dealing with side effects, right? Sometimes if somebody has 2 conditions, and that you can treat, that's kind of a no-brainer. You have high blood pressure or anxiety, maybe a beta blocker will be good for you. You have trouble sleeping, maybe, a little bit of nortriptyline will help your insomnia and your headaches. But oftentimes we're dealing with, side effects that we don't want. Then we have Botox for chronic migraine. So chronic migraine is defined as 15 or more days of headache per month.
Mhm.
And at least the 8 of those headache days meet criteria for migraine, the ones we discussed before. Because sometimes as headaches become more chronic, not all of them are, have migraine features. But if someone has headaches more days than not, and at least 8 migraine days per month, then they have chronic migraine. And so Botox is a effective treatment for
How
chronic
effective is
migraine.
it?
Um, I would say, in my experience, probably about 75% of patients
Oh,
respond to Botox. Yeah, in terms of either frequency, decreased frequency, intensity, or duration of their headaches. Unfortunately, although it's very effective and has no systemic side effects, insurance, generally won't cover it unless someone's failed generally at least 2 of the standard oral preventives that I mentioned before, like a blood pressure medication or an anti-seizure, antidepressant medication.
and I presume it has to be repeated.
Yeah, it's given every 3 months. It's a
Mhm.
series the protocol is about 31 injections to the forehead, temples, back of the head, shoulders, and then it can be sort of adjusted according to where a patient's pain is.
And do people have to do that indeterminately, or is there a period of time when it actually?
Sometimes it's people have such a dramatic improvement that they don't even know if they have headaches anymore. So what I explain, why don't you try stretching it to 4 months and see what happens? And often they see things start to creep back, and they know, or not, and then they can make that judgment call. And then I mentioned that all these non-specific migraine treatments, even Botox, where although it became FDA approved for migraine in 2010, it wasn't developed initially for migraine. It was found accidentally
Right.
from the cosmetic indication to be helpful for migraine. But about 3 years ago, the first of 3 monthly injectables specifically indicated for migraine prevention became available. And these target CGRP, that protein that I mentioned before, but these are long acting. So they each have a half-life of about a month. So these are subcutaneous injections that patients can self-inject. And these have been revolutionary in terms of migraine prevention. As a whole, they're generally well tolerated and work well.
How well?
So in the studies, they probably each showed about a 20% difference between the treatment and placebo groups in what the parameter that's most looked at for a migraine preventative is a 50% reduction in days of headache. So at least there was a 20% difference between the placebo and treatment groups for all 3 of the injections.
This is a little bit tangential, but I heard that the placebo rate is high for migraine.
It's very high for migraine studies. That is true. So that's why I personally like to look at that placebo-adjusted response.
Why would it be so high for migraines?
Um, I don't know. I think there's certain expectation that that's something or people sort of latch on or a hope, or I think that's what it is. But I don't know. I don't know for sure.
I mean, could it be because this is one of your classic mind-body disorders where, the physical and the, mental are intertwined? Could that be?
That can be. That can definitely be playing a role.
Mm-hmm, mm-hmm. Okay, so you have those CGRP. What about that cephali? There's like some piece of.
Yeah, there's a couple devices that have been found to be helpful for migraine treatment. So cephali is a supraorbital nerve stimulator. It's worn here.
Mhm.
I find it most helpful for people that have pain there because it's specifically stimulating the nerve there. It has a preventive mode and an acute treatment mode. So it can be used every day, worn every day as a preventive and used during an acute attack. I mean, the issue with that is it's expensive and not covered by insurance. But some people find it helpful.
How helpful is it? A statistic?
I don't recall the statistics overall. In my experience, probably less than half of patients who try it, or more than half of patients who try it, return it within the trial period.
Mm-hmm.
Then another device, this is newer, is called Neurivio. And it was actually developed in Israel. And it's interesting because it's sort of a unique technology. It's called a remote electrical neuromodulator. Essentially, it's worn on the arm, but by stimulating nerve fibers, it interrupts the pain going on in the head during a migraine attack. And that was found to be about 70% effective.
Oh, wow. Is that available now?
It's available, yeah. And they just got an indication for teens as well. So that's really nice
really?
because there aren't that many treatments for
Right,
it.
you mentioned the triptans. The triptans cannot be used on children, correct?
Some of the triptans can be used
Can they?
yeah. So specifically rizatriptan, zomotriptan have pediatric doses.
Under 12.
Under 12.
Oh, wow.
Yeah.
many of the time in children, I mean, this is, I don't see, children who in general have migraine so bad that they can't just take, say, ibuprofen or Tylenol and have them.
Oh,
Well,
there
sure it
are
exists,
some.
I just don't see
There
them.
are
So
some.
I just
Yeah,
haven't
yeah,
seen
yeah.
them. I'd
Yeah,
send them to a neurologist if I did.
yeah, those kids that vomit uncontrollably. Yeah.
Right. So that's good to know. That's good to know. What are some lifestyle changes that could help? Because I mentioned before brain body. I mean, I have this. I know that stress interacts, we didn't even really, we talked about food triggers, but we didn't really talk about other kinds of triggers. I mean, certainly stress
Yeah, yeah.
trigger,
So yeah, stress
sleeping.
is a trigger for sure. So, the way I explain it to patients is, when we're going through something stressful or painful, our bodies don't know the difference, that tiger chasing us type of thing, the whole fight or flight reaction. So, um, having a way of dealing with stress is very important. I emphasize that it's important to learn techniques that you can just call on at any time. So you have to spend time. You have to learn it so that when you're going through an episode, you can kind of call on these techniques. And different things speak to different people, right? So some people like meditation, and other people, just say
Right.
that that doesn't work for them. There's definitely good apps for this. Another technique for people that I think are a little bit more doers than um, meditators. There's something called progressive muscle relaxation. So I think there's a technique that can work, speak to, yeah, you have to find that technique, but it is very important. The way, I try to explain to people that, because sometimes people are like, well, what should I do? Should I be doing the exercise, or should I be taking these supplements, or should I be using the medication? I say everything, because, migraine the triggers are many. So I feel like attacking it from as many directions as you can. I don't believe in starting 10 medications at once, but, layering on these different interventions, I think is the most helpful.
Right. Especially because no intervention is 100%.
Right.
Right. I mean, you're talking about a difference from a relatively high placebo effect to the medication effect can be 20% maybe. Right. I mean, it's not, I think people shouldn't expect magic. I think that, I mean,
Yes.
the way I
Yeah.
look at it is that I try to approach, my having migraines is trying to look at the things I do with my life as part of the treatment. So I find that if you don't go to sleep at the same time, it's not even a matter of staying up too late. It's erratic sleep patterns
For sure.
is a major
Yeah.
trigger for not just for me, but for many people.
Yeah. And even sleeping in, which is so annoying, right?
Yes,
Like you
yes,
want
yes.
you want to
As a
sleep
night
in.
person who wants to sleep in, yes, it is so annoying. Those are the
Yeah.
days that I'm most likely to get the migraines, is the day I sleep in. And by the way, I find also that it's after the stress. It's not necessarily during the stress.
Right. Because during the stress, the adrenaline gets you through. It's that abrupt drop in it that triggers the pain. That's very common, after the project is done, after the test, or just weekends in general, when someone, tells me every weekend is ruined by a headache. So I'm like, there's different things let's think about. Let's think about your stress level, and the way to deal with that is having a regular means of stress reduction, or perhaps you're sleeping in, or your caffeine intake is different or later than your weekday.
Right. So not just expecting a medication, but looking at all the different factors, eating and drinking. I tell people always have a drink and always have a snack. Do not skip meals. Putting aside fasting for all the holidays that we have to do. We're not going to talk
Yes.
about that.
Yes. I have tricks for that too, but yes.
Yeah.
Yeah. But we'll talk separate. Yeah. Yeah. Yeah.
Okay.
But yeah, those, right. The thing with migraine is, it is a chronic condition, and you have to realize that you have to you have to be careful. You have to think about these various triggers, and it especially the layering on of triggers, right? So maybe sometimes you'll get away with a glass of wine, but not before your period necessarily, or not when you're going through a stressful time. That's when you have to be extra careful about whatever, your sleep, your hydration, not skipping meals, those sorts of things.
Can we talk about hormonal triggers through the woman's life? Because again, it's
Yeah.
more common in women, but the phase you're in can affect have
Yeah,
severe migraines.
absolutely, absolutely. So, probably 40% of women or so will note a relationship between their menses and
Mhm.
migraine. Um, so the thing about menstrual migraine is it's more difficult. It tends to last longer. It tends to be more intense, and just less more treatment resistant. So I think the best thing with menstrual migraine is to get ahead of it. So if your periods are predictable and your headaches associated with your periods are predictable, that's sort of the best situation. So, someone might be on hormonal birth control. Let's say they take a placebo pill on Sunday, their period starts Tuesday, but their headache starts Monday. Then I might tell them to take something along with when they start their placebo pill, take something to prevent um, a headache, perhaps a long-acting anti-inflammatory, um, that sort of strategy.
And this is because of the drop in estrogen.
Yeah.
So how would that affect after menopause?
Right. So in general, 2/3 of women that go through natural menopause, their headaches improve. So that's when they're fully through menopause.
Okay, and then
Um,
lucky ones like me.
that persists. So that, yeah,
Or
and
worsen, or
sometimes
worsen.
and worse. Right.
Mhm.
Perimenopause is often a really bad time for women just because of the wild fluctuations in hormones. But sometimes when full on menopause, but not definitely not always. And it's interesting that even postmenopausal women, the frequency of migraine is still higher than in men. So there's always, yeah, definitely a hormonal chain
Mhm.
connection.
And how is the treatment different for people who are in chronic daily headache? And what is chronic day? I mean, chronic daily headache is what it sounds like, right? You have it all the time.
Right,
Is that
right.
different for people
So
who have migraines?
there's different types of chronic daily headache, but if it's chronic migraine, then we treat it as we have some a couple all the treatments I mentioned for prevention plus Botox as an option. But whether if someone has high frequency headache, if someone has 9 or more days of headache a month, you definitely want to be more aggressive because they're at risk for progressing to a chronic migraine. There's really no difference between someone who has 12 and 15 days of headache a month. They're at risk. And some of the risk factors that we see that seem to be connected with chronic migraine. Why do some people have episodic and some people have chronic? Some of the common comorbidities are untreated depression and anxiety. So that's something I like to address with my patients.
Mhm.
A history of head or neck trauma, obesity, sleep apnea, um, teeth grinding, smoking, and medication and caffeine overuse, the things we touched on before. Those are all some of the risk factors for progressing to chronic migraine. So try to
Now,
address them.
are there alternative medication approaches? And how effective
Sure.
are they?
Yeah. So there are some natural products that have been found to be helpful for migraine. Magnesium probably has the most evidence of being helpful. So we generally recommend 400 milligrams a day of magnesium. The glycinate or glycinate form seems to be, better tolerated than other forms. Other supplements that seem to that have some evidence of being helpful are riboflavin or B2 and coenzyme Q10. And that coenzyme Q10 has also been studied specifically in children.
And I believe that there is a proprietary formula called Microleaf. I think it might have all three of those in it.
Yeah, a microleaf has magnesium, B2, and feverfew, I believe.
Mhm. How effective are these?
Um, I mean, as each one separately, I don't know the numbers off. I mean, it's not I don't think they necessarily compare. I mean, overall, my experience is that they're not as effective as prescription medications, but I really recommend them in everyone because they're very benign. I mean, the only magnesium can cause diarrhea, especially the oxide form, but uh, they're overall they're typically less effective than the prescription medications, but they're enough for some patients.
Right, and you could try it, and you could do what I did, run out, and it doesn't make a difference, and you realize it did nothing.
Yeah, but you have to, yeah, but you ran out. You have to give it a few weeks,
Right.
right? So
Yeah,
you
yeah,
know, it's
months,
not,
yeah. Doesn't
yeah,
always,
that's a, yeah,
there's nothing wrong with saying it didn't work. One of the problems is you start on something and you're afraid to stop it,
right,
and it's doing nothing, and you're paying,
right, right.
taking,
If you give it a good, few weeks, I think that's
but
fair.
it's worth a shot. And again, if you go back to the placebo effect, the placebo effect is so dismissed. If it makes you better, who cares why?
That's true. That's true. If you're talking about something benign, then yeah, I agree.
And also there are other kinds of treatments, right?
Right. Acupuncture has been found to be helpful for migraine. Cognitive behavioral therapy, especially, some studies specifically looked at that for children, like combination medication and CBT, other, biofeedback.
Mhm. Right. So you don't know what will work for you. It's worth, looking into and trying different things.
Yeah. Aerobic exercise. Yeah, that's another biggie.
And exercise makes the headache worse when you have it, though. But if you
Right. But overall, aerobic exercise has been found to be as helpful as some of the migraine preventives, a regular, regular program of aerobic exercise.
So interesting. What about during pregnancy?
Yeah, so that is tricky. Many women improve, especially in their second and third trimesters, especially women that have menstrual migraine. They tend to feel sometimes it's the best time of their lives, right? But the first trimester is often kind of dicey because again the large fluctuations. Treatments are really limited. That's the issue. So for those, I tend to see the people that don't feel better during pregnancy, and it's tough. But we have some options. Tylenol doesn't work for a lot of people. There are other things that sometimes, rarely, triptans are okayed in pregnancy. Triptans are probably safe, and in some situations we do use them. There's sumatriptan has been around now for almost 30 years, so there's we have data from registries suggesting that it's most likely safe and probably better than the alternatives that we've suggested all along, like opiates for more severe headaches. Not something we love. Other things that we do to sometimes we'll give metoclopramide, the anti-nausea medication, which helps with headache pain as well. Sometimes we'll do nerve blocks with an injection of a local anesthetic to help break a cycle. Some for women that had a benefit from Botox before pregnancy, with the blessing of their OB, will continue it if so definitely less is more. So all those things that I say, all you have to be much more careful in pregnancy, and many of the preventive medications we don't use, and certainly not the injectable medications that I mentioned, the anti-CGRP medications. But sometimes some of the daily preventatives can be okay, like a beta blocker in some cases.
And what about while trying to conceive? Is there any issues that come up? And one thing I'm thinking about is birth control. I know there's been talk about it sometimes being a contraindication to be on the pill.
Oh, wait, sorry. In terms of
the migraines, having a history of migraines, I think it's
right. So it's really aura that puts women at increased risk of stroke and cardiovascular disease. So that's when you have to be more careful about estrogen containing birth control. But it's always a risk benefit discussion. So some women really need estrogen. I explain. Sometimes we'll get the OBs asking us, or but I explain it's a discussion between your GYN, as long as you know that there is an increased risk with estrogen, just to be aware of it, but generally not an issue for women that don't have aura. And then those women that are deemed to be at risk may be on a progesterone only birth control, which doesn't have that risk.
Being on the pill exacerbate migraine? Does it make it worse?
Yes and no. So that's for some women, yes, and for some women, different formulations. That's sometimes when I see women, that's when their headaches start, and when they fiddled around with either started or stopped, and it's so hard to predict, who who will do better. Women that have menstrual migraine often do better on a continuous birth control, or just getting their periods quarterly. But it's so hard to predict
So can
who's
I
going to
make it
do.
both therapeutic or make it worse? It could be either. So interesting.
Yeah.
Are there issues with fertility, with having to do different, courses of medication because it could impact on that at all?
Oh, I mean, going through fertility treatments often worsens migraine. In women that have migraine, it often makes their migraine worse. Um,
Could the medication impact on fertility at all?
no. But many of the medications that we use, right, are not. Some of the preventatives that we use, like topiramate. We definitely want. I always, ask my patients to tell me about their pregnancy plans. I always ask when I see a patient if they're planning pregnancy within the year, because that affects my treatment choices. So, whereas the acute medications, while, some of them might be okay because they have such short half-lives, as long, if you're getting your period or in the second half, or the first half of the month, it might be okay. But in terms of preventive, certain ones you certainly wouldn't want someone on while they're actively trying to conceive.
Right, so who needs to see a headache specialist as opposed to just their regular physician?
So I think that most people will start with their regular physician and do just fine. I think if there usually what I'll find is that depending on the comfort level of the general doctor, they might try one or two acute treatments, and if that doesn't work, they might refer somebody. They might try one preventive, and if that doesn't help. So I think that's a great place for most people to start. Obviously, if somebody has something unusual or something, if somebody planning pregnancy, let's say, I think that that is a little bit more nuanced. But in general, most people can start with their primary care doctor.
And then go to the specialist when it's not working. All right, so this is a lot of really, really good information, and I thank you so, so much for sharing this with me.
Of course. Thank you for
Really
having me.
appreciate it. Thank you.
Take care.
You too.